We're going to go ahead and start with the presentation. Our first speaker, I'm using my version, is Dr. Ami Desai. She's from the University of Chicago, Comer Children's Hospital. What Ami does for us at this conference is, again, if we have new families, sometimes you don't know the basics of what's going on in the terminology, and so what Ami does for us every year is mainly, for the newer families that are here. So Dr. Desai has received her MD at Robert Wood Johnson Medical School and completed her residency at Yale New Haven Hospital and her fellowship at Children's Hospital of Philadelphia. Her areas of expertise are sarcomas and neuroblastoma and other solid tumor cancers, as well as developmental therapeutics and adolescent and young adult cancer care. She's a member of numerous organizations, including ASCO, the COG, where else do I have? American Society of Pediatric Hematology, Oncology, and numerous others. She is also involved in numerous clinical trials at Comer Children's, and her talk today is, again going to be on neuroblastoma basics. Dr. Ami Desai.
There we go. Good morning, everyone. It's always such a pleasure to be here, and a big thank you to CNCF and Pat for hosting this conference, and hopefully you'll find the next 2 days educational, and as Pat mentioned, please don't hesitate to come to us at breaks or afterwards. We're happy to help answer any questions that may come up along the way. Also, as Pat mentioned, a large part of my talk is really to lay the groundwork for the future talks you're going to hear today and tomorrow, and to just review some of the basic terminology and epidemiology and other clinical trial overviews for neuroblastoma. So neuroblastoma is the most common solid extracranial malignancy in children, or basically outside of the CNS. It originates from neural crest tissue, which presents on the adrenal glands, which sit right above your kidneys, as well as the sympathetic ganglia that go anywhere from your neck into your pelvis. So neuroblastoma can present anywhere along the sympathetic chain. And it has a broad spectrum of clinical behavior, which is really reflective of the tumor biology. So patients with low-risk disease may be treated by observation or surgery. Patients with intermediate risk disease may receive chemotherapy plus minus surgery, and patients with high-risk disease receive intensive multimodality therapy. There are about 700 to 800 new cases of neuroblastoma per year in the US, and it accounts for about 8% of childhood cancers. And approximately half of all newly diagnosed patients will have high-risk disease. And there is a higher prevalence of high-risk disease in Blacks and Native Americans. And we just recently published an updated manuscript that shows that this is still present in current day. The incidence is really highest in infancy and early childhood. And most cases of neuroblastoma tend to happen before the age of 10. So there's been no consistent environmental factor identified. And actually, it's a genetic predisposition to neuroblastoma is actually quite rare as well. About 1% to 2% of patients may have a family history of neuroblastoma, and about 3% to 4% of patients may present with bilateral or multifocal disease without a family history, but which may prompt us to think of a potential predisposition to neuroblastoma. So when we talk about genetic mutations, there are ones that may just be present in the tumor, which we call somatic mutations, but you can also have germline mutations, or something that's present in all the cells of your body, and that can either be inherited or present de novo in a patient for the very first time. So the ones we commonly think about are germline mutations in ALK or FOX2B mutations, and ALK can, again, just be present in the tumors, but can also potentially present within the germline as well. But then also an expert panel has grouped together over the last few years and just presented some updated guidelines. And there are some syndromes that may be associated with predisposition to neuroblastoma. And the ones where surveillance is recommended, or neuroblastoma-specific surveillance is recommended, is Costello syndrome, Beckwith-Wiedemann syndrome when there's a CDKN1C germline mutation, Weaver syndrome, duplication 2p24, and Rohat syndrome. And of course, there are other syndromes that may also be associated with neuroblastoma, but the incidence is quite low, and at this time, this expert panel doesn't recommend neuroblastoma-specific surveillance for those other groups. So one thing whenever I meet a new family is everyone wants to know why. So we talked a little bit about the genetics, and they want to also know, is there a role for screening in the general population? So in the past, people did think that maybe we should screen for neuroblastoma through urine catecholamines, urine HVA and VMA. But when this was done in infants, what was seen was that it really increased the rate of diagnosis of early stage disease, but not really aggressive later stage disease. There was no decrease in mortality, and virtually all of these tumors had favorable biology. So often interventions were happening for children causing more morbidity, and the children who were being identified were those who otherwise would have gone on to have favorable outcomes. So again, the conclusion was that tumors diagnosed in infants by mass screening are unlikely to progress to life-threatening advanced stage disease, and many are likely to spontaneously regress. As for the clinical presentation of neuroblastoma, it can present as an asymptomatic mass, again, anywhere from the neck into the pelvis. It may present as Horner syndrome if there's compression of the stellate ganglion. It could also present as spinal cord compression if there's tumor going into the spinal space. Hepatomegaly, being pale, skin lesions, systemic symptoms such as weight loss, irritability, fever, hypertension. We often will see potentially with high-risk disease. Bone pain, limp, or refusal to walk, where the oncology team may be consulted if a child may have a fever of unknown origin or a limp and they're evaluating for an underlying malignancy. And raccoon eyes, as you can see on the screen. So as we talked about, neuroblastoma primarily happens in children and infants, and it can present in older patients or in the adolescent young adult population, and also rarely in adults as well. So the adolescent young adult population is, again, a rare population, accounting for less than 5% of neuroblastoma diagnoses. And the phenotype, or how these patients present and how their course is very different than the younger children. And it tends to be more indolent, and they don't respond as well to chemotherapy. And their underlying biology, we think, is also different from younger children. And there's definitely a need for novel therapies for this group. So as providers, what do we do when we first encounter a patient who we're suspecting neuroblastoma? Of course, we do a thorough history and physical exam. There are certain laboratory tests that we also obtain that may help indicate whether the underlying process is neuroblastoma. We also order tumor imaging, and patients undergo either a CT or MRI of the primary tumor, as well as a full body scan to look for other areas of metastatic disease, such as an MIBG scan or a PET scan. And we also obtain a piece of tissue to look under the microscope to confirm the diagnosis, as well as send off other additional biology studies for the tumor. And we also check the bilateral bone marrow aspirates and biopsies, as well as neuroblastoma can present in the bone marrow or metastasize to the bone marrow. So to have a diagnosis of neuroblastoma, it's having unequivocal pathologic diagnosis by tumor tissue, or if there is not tumor tissue from the primary tumor in area of metastatic disease, it's the identification of neuroblastoma cells in the bone marrow plus elevated urinary catecholamines. So most of the audience would hopefully know at this point what an MIBG scan, but for those who may not know, I was just going to do a quick overview of this as well too. So about 90% of neuroblastomas are MIBG avid at diagnosis, and about 10% are not, and those patients are followed with PET scans. But MIBG is an analog of norepinephrine that's labeled with radioactive iodine and taken up by neuroblastoma cells. And essentially that helps the neuroblastoma cells light up, and for us to be able to quantify how much disease a patient may have. And then this is something we can then follow over time. When looking at these scans, it is normal to have uptake in the salivary glands, the bladder, and the liver. So those areas don't concern us when we look at these scans. And as you may also know, we also want to make sure we protect the thyroid, as the thyroid can take up MIBG as well. So we do have our patients have thyroid protection with SSKI to avoid hypothyroidism in the future. And this is an example of just what we call our Curie man, or how we help quantify disease using a Curie score on MIBG scans. So there are 10 regions that we look at. Regions 1 to 9 represent the skeleton, and region 10 is the soft tissue. And again, this helps us score how much disease there is at diagnosis and what response is along the way. So here is a slide just summarizing some of the neuroblastoma prognostic markers that have been identified over the last few decades. And I always like presenting this slide, and of course this was given as a courtesy to me from Dr. Cohn. And what this shows is, again, 5 of the characteristics we've traditionally used as prognostic factors in risk assignment within the COG. So we use stage, age, MICAN status, ploidy, histology, and some of these earlier prognostic markers to help determine risk stratification. And then more recently, the updated risk stratification group also includes the use of segmental chromosomal aberrations. So again, on the left of the screen, you can see the prognostic factors we've traditionally used: age, stage, MICAN status, histology as favorable or unfavorable, and DNA content or tumor cell ploidy. And in the prior risk stratification, we then came up with this table to help us put these 5 factors together to then group patients into a risk group, and then risk group allows us to then decide what type of therapy a patient may need to give them the best outcomes. And the one thing I wanted to point out, that once you become older, once a patient is 18 months or older and has metastatic disease, that alone puts you in the high-risk category. So at that point, we like to still obtain all the other tumor biology, but age and stage alone at that point would put a patient within a high-risk category. And in the recent years, we have an updated staging system for neuroblastoma, or the INRG staging system. And this is a pre-treatment staging system, and it incorporates something called image-defined risk factors, or what we see on scans. And I'll go briefly into that on the next slide. But stage L1 is a tumor that's localized without what we call image-defined risk factors. An INRG stage L2 is a local regional tumor with 1 or more image-defined risk factor. Stage M simply means that there is metastatic disease. And stage MS is a unique group of patients that are younger children with INRG stage L1 or L2 tumors with really limited metastatic disease. And this is a group of patients that may also potentially have regression of their disease. And these are just some examples of image-defined risk factors. So this is what we work on with our radiologists to say, is this present on the scans? And what these categories represent really is tumor wrapping around really major vessels or close to organs that may cause compromise, but may reflect some more aggressive underlying biology of the tumor. And then this now is our updated COG risk classification system. So here, as we can see, we use those same 5 things we talked about earlier. And in some of the groups, as I'll show you on the next slide too, we also have incorporated some segmental chromosomal aberrations. So we start with our stage, and then we go into how age, tumor size, or extent of surgical resection and MICAN status may impact risk stratification for someone with an L1 tumor. And then here is the same slide for L2, M, and MS patients. And as you can see, the incorporation of SCAs, or segmental chromosomal aberrations, are now incorporated into this risk stratification. So what is our current treatment approach? We really try to tailor treatment according to predicted behavior based on the clinical characteristics and tumor biology, which essentially is summarized within our risk stratification group. And we know that it's not possible to learn what treatment is best for each patient if everyone is treated differently, and that's largely why we conduct clinical trials. And a series of clinical trials for patients with low, intermediate, and high-risk neuroblastoma have been ongoing for decades, which have really helped us try to optimize survival rates and minimize toxicity. So I'm going to now pivot a little bit into clinical trials for those who may not know as much about this or are just starting to learn about clinical trials for the first time. So clinical trials are studies involving people that may help make progress in preventing, diagnosing, and treating cancer. And each clinical trial follows a set of rules called a protocol, or sort of our cookbook of what to do next, that describes who can participate in the study and how the treatment will be given and monitored to keep patients safe. And clinical trials really remain the most reliable and accepted way to find out if a new treatment works better than what is considered standard of care. And for clinical trials, it really is important to learn as much about a trial as possible before participating. And it's really critical to talk to your doctor and research team to really help you understand what to expect from a trial and what the trial is investigating. So these are just some examples of things that might come to mind when talking to your provider about a clinical trial. You know, what clinical trials may be most appropriate for me or me being your child? What is the purpose of this clinical trial? Why does the research team think the drug will work? Why is this specific approach being studied? What other treatment options might be available to me, including other trials? And what organization is sponsoring the trial? Is it through a consortia or industry or another group? So there are clinical trial requirements that we review to see if a patient is eligible for a study. So who can participate on a trial is really determined by inclusion and exclusion criteria. And these criteria are largely based on one's medical history, including in things such as age, the type of disease one may have, and the current clinical status of a patient or what their health is. And inclusion criteria really try to help make sure that all people in the trial are medically similar. So for example, there may be a trial that's specific for just patients with neuroblastoma. And if people have too many medical differences, it's difficult to sometimes interpret those results. And exclusion criteria are there to truly help keep patients safe as well. And there are three common phases that we talk about when talking about clinical trials. A phase 1 trial is a clinical trial that are used to show if a new treatment is safe for a small group of patients and really to help us find the right dose and safety profile of a drug. A phase 2 trial then says, okay, now we have the right dose of the drug. How well does it work within a group of patients that we think or hypothesize it could potentially work well for? And then phase 3 clinical trials really compare the new treatment with what is considered standard of care within a large group of people. So at diagnosis, you largely will see phase 3 and sometimes phase 2 clinical trials. So phase 3 clinical trials compare a new treatment that has shown promising results when used for a small group of patients versus the current standard of care. And then data are gathered from large groups of patients to find out whether the new treatment is more effective and potentially have fewer side effects than the current standard treatment. And phase 3 trials tend to be randomized, where patients receive either the standard of care or the investigational therapy at random. And now I'm going to go into a few phase 3 trials that have been conducted in patients with low, intermediate, and high-risk disease, and how that has brought us to how we treat patients currently. So this is P9641, which was a phase 3 trial for patients with low-risk neuroblastoma. And here the question was, could primary surgical therapy for low-risk neuroblastoma be enough for some patients? And could they be observed and not receive additional chemotherapy? So the objective was to demonstrate if surgery alone would achieve a 3-year overall survival of greater than or equal to 95% for patients with asymptomatic, the older staging system, INSS stage 2A or 2B neuroblastoma, which tend to be local regional tumors or localized tumors. And asymptomatic patients would receive surgery alone, and symptomatic patients would receive 2 to 4 cycles of chemotherapy or surgery. And those symptomatic patients may have compression from the tumor, or maybe that it may risk an organ that's nearby, or that enough tumor was not removed. And indeed, they were able to find that excellent outcomes were maintained if patients received surgery alone in certain subgroups of patients. As for intermediate risk neuroblastoma, this was a trial that used response and biology-based therapy to see if they could reduce therapy for subsets of patients while maintaining excellent 3-year overall survival of greater than or equal to 95%. And here again, they used things such as stage and biologic features of the tumor to then assign a certain number of cycles of therapy with an endpoint of developing a partial response of the primary tumor. So patients got anywhere from 2 to 8 cycles of chemotherapy, and indeed, they also saw excellent 3-year survivals with the initial study, and most recently, there was an updated publication showing long-term outcomes of 5 and 10 years were maintained for this group of patients using a response and biology-based treatment. And now we move on to high-risk neuroblastoma. So there have also been a series of trials, and a few will be highlighted here, that has really taken us to how we, from the COG perspective, treat neuroblastoma to date. So CCG 3891 investigated whether myeloablative chemotherapy and autologous stem cell transplant and consolidation could potentially improve outcomes compared to continued chemotherapy after induction chemotherapy. And what was seen was that myeloablative chemo plus autologous stem cell transplant did improve event-free survival for patients with high-risk neuroblastoma. Then the Children's Oncology Group study ANBL 0032 then looked at whether the addition of immunotherapy with the anti-GD2 antibody dinutuximab added to the standard of care isotretinoin would improve outcomes for patients. And indeed, at 2 years, the event-free and overall survival was superior for those randomized to the immunotherapy group, and this study was closed early, and the immunotherapy arm remained open for patients to have access to drug and to obtain additional data for this group of patients. And then the Children's Oncology Group study ANBL 0532 looked at single versus tandem transplant and consolidation. And here they also saw that for patients who were randomized to receive tandem autologous stem cell transplant had superior outcomes compared to those who underwent a single transplant, particularly when followed by immunotherapy. So that brings us to present day what is considered the COG standard of care for high-risk neuroblastoma. So this includes multi-agent chemotherapy and induction and surgery of the primary tumor, tandem autologous stem cell transplant and radiation and consolidation, followed by post-consolidation immunotherapy. And I've added the little star there to introduce the next slide, as data over this past year or so now talks about maintenance therapy after completing this intensive first part of therapy. So I'm sure this group is well aware of the data and the news of DFMO, and DFMO is an irreversible covalent inhibitor of ornithine decarboxylase, or ODC1 protein. And DFMO essentially depletes polyamines necessary for tumor survival in higher doses than what is currently being administered for 2 years in the maintenance setting after completing the intensive multimodality frontline therapy. At these higher doses, it's also being investigated to see if it can perhaps enhance chemoimmunotherapy, and this is being studied on a Children's Oncology Group trial, ANBL 1821, as the hypothesis that DFMO may potentially enhance chemosensitivity and also have immunomodulatory effects, perhaps enhancing chemoimmunotherapy for patients. So as for back to maintenance DFMO, there was a phase 2 study, single-arm study of DFMO following post-consolidation immunotherapy in patients in remission. And what was found was that DFMO did improve survival compared to historical controls, again, because this was a single-arm study. But then most recently, there was an analysis done using propensity score that showed that there was a decreased risk of relapse in a simulated randomized trial using ANBL 0032 data as the historical control. And when the FDA reviewed this data and had a committee to review this data, there was FDA approval for this agent in December of 2023. So now patients can receive, if they've had a partial response or better, DFMO for 2 years after completing frontline therapy. So pivoting back to the sequential studies that have happened for high-risk neuroblastoma over the years, we can see that there have been incremental increases in both event-free and overall survival through these sequential studies. However, we all acknowledge that we can do better and that our studies moving forward are trying to see how can we further improve outcomes for our patients. So the most recent phase 3 trial for neuroblastoma was ANBL 1531, and this recently closed in September of 2023. And ANBL 1531 investigated whether the addition of I-131 MIBG therapy, which we'll talk about towards the end of this presentation as well, into induction, because it is active in the relapse setting, could it potentially improve outcomes for patients in the frontline setting. Also, the study included an arm where patients were non-randomly assigned to if their tumors demonstrated an ALK aberration. And what they're also looking at is whether the addition of lorlatinib to all phases of therapy with some intermittent breaks in between could potentially improve survival when compared to the standard arm of the study, or which serves essentially as a control. And then ANBL 1231 is the currently open phase 3 study for high-risk neuroblastoma that opened in April of this year. And they are now looking at whether the addition of the anti-GD2 antibody dinutuximab to cycles 2 to 5 of induction, or essentially getting chemoimmunotherapy in induction, could potentially improve event-free survival for patients with high-risk neuroblastoma when compared to what's considered standard of care. So now we're going to move on to some highlights of targeted therapies, and this is going to be really just to give you the landscape of what potential targeted therapies are for our patients, and then the talks you'll hear over the next 2 days will further review how some combinations and some other clinical trials are building off some of these initial studies. So anti-GD2 antibodies. So the Desai alloganglioside GD2 is uniformly expressed by neuroblastoma, and as we talked about earlier, we are able to give targeted anti-GD2 therapy in post-consolidation for patients, and now we're seeing whether it can also be given in induction and improve survival for our patients. And there are multiple anti-GD2 antibodies. So there's dinutuximab beta, which is commonly used in Europe, and naxitamab, which is also commercially available. And these antibodies have been given alone, but they've also been given in combination with chemotherapy, which has been very active in the relapse and refractory setting. And the side effect profile of these drugs really tend to be allergic type reactions and pain, because GD2 is also expressed on your long nerves. So we do make sure we manage pain for patients who are receiving these drugs. And you will also hear during the course of the next 2 days as well, too, some cellular therapies targeting GD2. So there are other immunotherapeutic strategies targeting GD2. I-131 MIBG therapy is really in many ways a similar concept to the scans, I-123 MIBG scans, but with a higher radiation dose. So essentially the neuroblastoma cells pick up the MIBG and it's attached to a radioactive isotope, which serves as like localized radiation to neuroblastoma. And traditionally this requires being in a lead room or shields to protect family and staff from radiation exposure. And we also generally give stem cells after patients receive this, as it can impact the bone marrow and for patients to have their counts come back faster. And as I mentioned, this is being studied as part of a frontline therapy for high-risk neuroblastoma. We know that it is active in the relapse setting, and now we will await the data to see if it has improved event-free survival with its introduction into induction therapy. And the next 2 slides are just a few scans of a patient who had a lot of MIBG avidity going into MIBG therapy. And then when a patient is admitted for MIBG therapy, we do a scan prior to them being discharged, just to show that the MIBG is taken up by the neuroblastoma cells. And often families may see this report and think, oh my goodness, this sounds worse than what I had initially, but we don't make any decisions based on that scan. We expect it to be brighter than the scan that was done pre-therapy. And then 6 to 8 weeks after therapy and when the MIBGs essentially out of your system, we do a scan with the hopes that we've cleared some of the disease. And this is an example of a patient who had a nice response to MIBG therapy. And again, here's another example of a patient who had a nice response to MIBG therapy. So ALK. So ALK is present in about 14% of tumors of children with high-risk neuroblastoma at diagnosis, and this can be an activating mutation or amplification. We do know in the relapse setting that the percentage is largely higher than this as well. And there are two agents that have been studied in neuroblastoma in early phase trials to give us the right dose for our patients moving forward, and one has been crizotinib, and then a more recent third-generation ALK inhibitor, lorlatinib. And as you may know, crizotinib was the original ALK inhibitor incorporated into the frontline phase 3 study ANBL 1531. And as lorlatinib came along and we had a right dose for our patients, this agent has now replaced crizotinib in 1531. So I'm going to end the talk now. We talked a lot about therapy, we talked about frontline therapy, potentially relapse therapies, but I want to acknowledge that there are a lot of late effects to the therapies that we do give our patients, and we are very aware of this, and ideally what we would like to do is to optimize our outcomes, but really try to decrease toxicity for our patients, and many people are working on identifying what exactly all the toxicities are with current era therapy, and how can we try to mitigate some of these toxicities or monitor for them in the future. So patients will receive anthracycline drugs, which may have cardiac impact, or if someone has radiation near their chest, that can potentially affect your heart in the future as well, too. There can be endocrine side effects, and along with that, we'll talk about impact on fertility, which we'll hear in our next talk as well, and how we try to incorporate fertility preservation for our patients early on in therapy. Ototoxicity, patients will receive a fair amount of platinum during their therapy, and this may impact high-frequency hearing loss. Second malignancies are something that we monitor for as well. There can be neurocognitive impact as well as impact on the lungs, again, based on radiation or the types of chemotherapy someone is receiving, even during the transplant phase. There can be impact on the kidney, again, from the chemotherapy or certain surgical procedures as well. So I just wanted to note that Doctors Tara Henderson and Lisa Diller have really made a great effort in trying to identify what are the late effects after high-risk neuroblastoma therapy. And there was a study that opened in 2016 that's now closed to accrual that is really trying to identify, again, what is the true incidence of some of these adverse events in high-risk patients after being treated in the current era of our treatments, and to determine the impact of these events on health-related quality of life. And there is really detailed data collection as part of this study that we hope will help inform our treatments moving forward and our identification of these late effects. So I just want to end by saying there is a lot of ongoing research. We have really made a lot of strides, but we all know that there is a lot more to do. And I hope you can feel invigorated over the next 2 days about all of the active research going on right now and what we look forward to in the future, and that everyone is very invested in improving the outcomes for all of our patients, whether it comes from, again, improving overall survival, but also decreasing toxicity for our patients. And a lot of this is collaboration between laboratory scientists and clinical trialists, also to be able to further refine risk stratification and provide more precise treatments to our patients, to identify biomarkers of therapy response and resistance, and you'll hear talks from Dr. Applebaum and Dr. Reynolds about some of this as well too. And there is an ongoing effort to look at social determinants of health as well, and how does the environment one is in also potentially impact the outcomes for our patients, and what is the experience for patients also going through frontline and relapse therapy. As we know, it doesn't end with the end of therapy, and that we want to continue to take care of our patients for the whole continuum of their life. So again, I just wanted to end by saying thank you to our patients and their families, and of course to the CNCF, and especially Pat for putting together such a wonderful conference. And again, please don't hesitate to reach out to any of us if you have any questions. Thank you. Even if you speak loud, I can.
I don't know if that was on or not. I didn't see.
I'll just speak loud.
Repeat the question so that.
Yep.
So there's been a lot of benefits to targeting the GD2 protein. Are there other proteins on the cell surface, free, that are being targeted?
Yeah. Yep. No, that's an excellent question. There are active efforts to look at different things expressed on neuroblastoma, and there are, for example, cellular therapies that are not just against GD2, but I think GPC2 and other things as well too that people are looking into. There are some cellular therapies or immunotype therapies that are being developed, like CAR-T type therapies for this.
Okay, I have a question about the MIBG therapy. I'm curious to know about the toxicity that is involved, and then how does administering this frontline or otherwise, how does the toxicity associated with this treatment affect further treatment down the road if there is a relapse?
No, those are really great questions. So, and I'm sorry, I didn't listen to Dr. Thiel, and I didn't repeat the question into the microphone, but this one we heard. So MIBG therapy tends to be pretty well tolerated for the most part. When the infusion goes in, there can be some nausea, there can be high blood pressure or blood pressure changes that we monitor for. But after the infusion is complete, it's a little bit anticlimactic for the next few days while someone is isolated until their radiation levels are low enough to leave the room. When it's given with other agents, which you'll hear about over the next 2 days as well too, there may be some other potential side effects. In the relapse setting, we have been giving it with another drug called Vernistat, and we will see the results of that study and see if there are any other additional side effects that we're seeing compared to MIBG alone. And there is some data from a phase 2 trial to date of that as well. As to what it can do down the line, so MIBG therapy, as I mentioned, can really suppress your blood counts, and we either try to have the blood counts come back faster by administering stem cells. Like at our institution, we just standardly do this 2 weeks after an MIBG infusion, and many of the protocols are written that way. In the older expanded access protocol, you can sometimes wait to give some growth factor and try to boost the counts before wanting to give stem cells. But I think most of us try to administer stem cells early, and that's how the frontline study was written as well too. The dose was a little bit lower in the frontline study, just because it was being given after and in the midst of chemotherapy as well too, and to avoid potential side effects down the road that were seen in some of the pilot studies of introducing MIBG in the frontline setting.
I have a question over here. First of all, thank you for the nice introduction. I'm Kyle Orwig from the University of Pittsburgh. I have a couple of questions. They're pretty naive because I'm not an expert at neuroblastoma, but you mentioned high-risk disease. Does that also equate to high level, more toxic therapies? If it's a higher risk disease, is it a more toxic therapy?
So risk stratification, yes, really then guides us to how much therapy one should receive. And having high risk disease will mean that you do get more intensive therapy. So again, this includes chemotherapy, surgery, high-dose chemo stem cell rescue, or what we say tandem transplant, radiation, and immunotherapy. So the overall treatment duration is much longer than for low-risk or intermediate-risk disease, and the intensity of therapy is higher too.
And one of the other things you mentioned was a list of markers that are indicative of neuroblastoma or diagnostic of neuroblastoma. And my question is, when a patient is going through the workup, are they routinely getting pathological assessment and testing for these markers so that you would know which marker that they're positive for? I have reasons for asking these questions.
So at diagnosis, we do additional testing to understand the biology of the tumor. When someone's disease may come back at relapse, we'll sometimes get a a sample of tissue as well, too, to see if the biology of the tumor may have changed. We don't frequently get biopsies during the course of frontline therapy, but we are checking things like the bone marrow that could potentially, you could look for certain things. If someone does have elevated, like urine catecholamines of HVA-VMA at diagnosis, that's something we can follow along the way to see if there's adequate response to therapy and just look at that pattern over time. I don't know if that answers your question.
It does. Thank you.
And hopefully there'll be more sophisticated approaches to looking at therapy response over time with validation of newer biomarkers.
Questions?
Great, thank you.